LiveStream featuring Dr. Oibek Rostomov, fertility specialist practicing in Adora Fertility, Brisbane. This afternoon, Dr. Oibek will talk about a research paper on elective freezing of embryos versus fresh embryo transfer in IVF, a multi-center randomized controlled trial in the UK. And for everybody's information, this live stream is being broadcasted across LinkedIn, Facebook, Twitter, YouTube, and other social media platforms. And for those who are watching us right now, please go ahead and message us and send it via rostomov.com.au or simply send a direct message to our official Facebook page. Mainly, Dr. Oibek Rostomov will be doing a critical appraisal as well of this research. And for everybody's information, it is the process of carefully and systematically examining research to judge its trustworthiness, its value, relevance in a particular context. Of course, to go through it accordingly, the RCT to be considered when appraising is a randomized controlled trial, or RCT, are its validity, methods, and of course, the results. And to go through it accordingly, let's welcome right now, ladies and gentlemen, fertility specialist from Adora Fertility, Brisbane, Dr. Oibek Rostomov. Doc, good afternoon.
Good afternoon, Jesse. Thanks for a kind introduction. Thanks everyone for watching this live stream. As you know, during last couple of weeks, we've been focusing on research question of whether transfer of fresh embryo compared to the frozen embryo will give better success in terms of clinical pregnancy or live births. So we have covered these 3 research papers already. So now we're moving on to the 4th RCT, which is elective freezing of embryos versus fresh embryo transfer in IVF, which is multicenter randomized controlled trial conducted in the UK. So we have a couple of more RCTs to cover specifically on this research question. Then we will move on to discuss observational studies, including large data analysis on fresh versus frozen transfer. After those reviews, we will have a full handle on whether actually fresh embryo transfer is better than frozen embryo transfer. Okay, so today's journal club has 2 parts. First part, we simply present the paper as it was reported in the journal. Then second, we critically appraise research methodology and outcomes of this paper. So the research was conducted in United Kingdom, and so 18 IVF clinics participated in this research study. So research period was from February 2016 till April 2019. So inclusion criteria for this research was all women undergoing IVF treatment cycle from age of 18 to 42 were invited to participate in the study, and the population was restricted to women undergoing first, second, or third IVF cycle. So the primary outcome of the research was healthy baby at term. So after first embryo transfer. So it is not live birth, it is healthy baby at term. They defined healthy baby during term from 37 weeks to 41 weeks. And healthy baby, they define healthy baby with a normal birth weight. So the research group wanted to achieve power of 60-90% power with alpha error of 0.05, and they assumed that the intervention, which was frozen transfer, would increase success by 8% in absolute terms, from the baseline of 17% to 24% in absolute terms, compared to control group, which was fresh embryo transfer. So the group set out to achieve sample size of 1,860 patients in total and 543 patients on each arm. So in terms of interventions, general interventions, the patients underwent normal ovarian stimulation as per UNIT's protocol. So 18 clinics participated in research study, and each clinic used their own routine practice for achieving ovarian stimulation for IVF, and patients underwent routine egg pickup according to the UNIT's protocol on day 3 of embryo development, and they were randomized to either control group or treatment group, which is frozen embryo transfer. So on day 3, all patients who are recruited to the study had their embryos checked. If they had more than 3 good quality embryo, they were included to the study. And all the patients who actually needed freeze all due to clinical reasons were excluded from the study. For example, if patient had a ovarian hyperstimulation syndrome, if they had hydrosalpinges, so if they needed to have a freeze all, then they were not included in the study. So let us look at what happened to patients who had a fresh transfer. So, okay, so this is allocation. So altogether, 619 patients were randomized. So initially, the study wanted to achieve 1,086 patients in total, but because of the difficulties with recruitment, so they had they had to stop the study and completed the study when they reached 619 patients in randomization. So in randomization, they used stratification according to patient criteria and according to the clinics, and also the randomized one-to-one using one-to-one randomization method with a centralized randomization methodology, which is best method of randomization. So in terms of allocation, 310 patients were allocated to the control group, which is up here, which is fresh embryo transfer, and 309 patients were allocated to frozen group. But if you look at the patients who actually had fresh embryo transfer, out of 310 patients, 282 patients actually had fresh embryo transfer, and out of 309 patients, 202 had a frozen transfer. So because as a lot of patients crossed over between the groups, mainly patients crossed over from frozen group to fresh transfer. After randomization, a lot of patients wished actually to have a fresh transfer. If they were randomized to frozen group, they said, no, we actually want to have a fresh transfer, and they crossed over to opposite arm of the study. And actually, the total number of crossovers was 30% from frozen to fresh. So 21 patients crossed over from frozen to fresh. Much less number of patients crossed over from frozen to fresh. So in terms of intervention for fresh transfer, clinics use their own protocol for fresh embryo transfer and luteal support, and approximately 93% of patients had a blastocyst embryo transfer, and approximately 81% had a single embryo transfer. Patients who were allocated to frozen embryo transfer had their embryos checked, and if they had more than 3 top-grade embryos, the embryos were incubated for that couple of days for until blastocyst stage, and when they reached blastocyst, all embryos were frozen for future use. So approximately 88% of embryos were frozen at the stage of blastocyst, and 12% were frozen at the stage of cleavage stage. So patients who were allocated to frozen group underwent frozen embryo transfer within 3 months of completion of fresh cycle, and the clinics used their own routine protocol for frozen embryo transfers. So 95% of patients had HRT frozen transfer cycle, and the luteal support was given according to routine clinical practice of participating 18 clinics. So again, 94% of patients had the blastocyst embryo transfer, and 83% patients had single embryo transfer. In these two arms, fresh versus frozen, proportion of blastocyst embryo transfer and single embryo transfer is very comparable in terms of numbers. So yeah, overall, if you look at the overall picture here, primarily this RCT looked by default fresh versus frozen embryo transfer at the blastocyst stage, which is unlike previous RCTs we reviewed. They primarily they did the embryo transfer on during cleavage stage. So this is a difference of this study compared to the previous studies. So now let us look at the result. So they did intention to treat analysis, which means the group of women who are allocated to certain group were analyzed in that group. For example, this 310 women couples allocated to control group had analysis of their results in that group. Although a lot of them, some of them crossed over to frozen, but still they were analyzed in that group, which is called intention to treat. That's actually best method of analysis. Same in frozen cycle, and they had an intention to treat analysis. Although a lot of patients crossed over, again, that's the best method of analysis. But again, also they did pair protocol analysis, and result of the pair protocol analysis was very similar to intention to treat analysis. So pair protocol analysis means that depending on what actual treatment they had, they get analyzed there, and the results were very comparable. So yeah, so in terms of another comment on crossover, so average 50 up to 15% of crossovers in general in RCTs are expected. More than 15% crossovers may affect the outcome, but using different type of analysis, you try and overcome this problem. So here, when they did ITT analysis, they found that 24% of patients in fresh group had healthy baby. So the 75 out of 309 patients had a healthy baby after first embryo transfer. So this study in this publication, they didn't look at cumulative live births, which means live births of all the embryos resulted from that cycle. They actually looked at the live births from the first embryo transfer, whether it was fresh or frozen cycle. And not live births, actually healthy baby. Live birth was a little bit higher. So overall healthy baby rate was 24.4% in fresh arm and 20.3% in frozen arm. In frozen arm, 62 babies were born. So it is a little bit less than fresh cycle. So here, although it's not statistically significant, there is some benefit according to this study, but there's a lot of deficiencies in terms of power calculation. We cannot, because of that, we cannot reach that conclusion with confidence. But if we don't take that into account, here we get a little bit of more babies if we do fresh embryo transfer. So the conclusion of the study here I'll read out. In conclusion, the results of this multicenter pragmatic RCT do not support a change to universal elective freeze policy on grounds of clinical or cost effectiveness, although the results were limited by not reaching full sample size as well as non-adherence. So essentially, here the conclusion is that we should not do freeze all for all patients because it does not increase our success. So you can do freeze all for various reasons, but you cannot just offer freeze all on the grounds of improving clinical pregnancy or healthy baby rate here. So, and the second thing is also study group is recognizing, although it's difficult to make this strong statement because the sample size, it wasn't reached, and essentially the weakness of the study is twofold. One is sample size wasn't reached, and second is non-adherence. Non-adherence means they had a disproportionately high crossover from frozen to fresh, which was 30%. This is end of first part of the presentation today.
Thank you so much, Doc, for that and for going through it accordingly. And then again, for everybody's information, we're going to move on right now with a critical appraisal, of course, of this research paper. And again, we'll be starting with the validity, moving on with the methods and results. If the validity is, of course, all answers are yes, we can continue with methods and results. So for the first question in validity, did the study address a clearly focused research question, Doc, considering, of course, was the study designed to assess the outcomes of an intervention, or is the research question focused in terms of, population studied, intervention given, comparator chosen, and outcomes measured?
Yes, so the research question was very precise, and and population was very well defined, intervention was very well defined, and comparator was chosen, and outcomes were measured. So yes, answer to this question is yes.
Thank you, Doc. Now, next one is, was the assignment of participants to interventions randomized?
Yes, the study group used centralized randomization method. Yes, they were randomized.
And finally, for the validity question, were all participants who entered the study accounted for at its conclusion?
Yes, so the group gives very clear chart of all patients who were recruited, and they accounted for every single participant who entered the study and consented for the study and randomized for the study. And this chart is there, and we can account for each and every single participant.
Thank you, Doc. Now, moving on with the methods, since we answered all of it with yes. Now, here we go, the blinding questions. First one is, were the participants blind to intervention they were given?
No, participants were not blind to intervention because patients had to know whether they are having fresh embryo transfer or frozen embryo transfer. Because of nature of the study, they were not blinded, and that was correct step.
Thank you, Doc. Next one is, were the investigators blind to the intervention they were giving to participants?
Again, due to nature of the study, investigators were not blinded. So because they had to know which patient is having fresh or frozen transfer. So investigators were involved in clinical care, and this is why they had to know, and so hence they were not blind.
All right, thank you, Doc. One last question for blinding. Were the people assessing and analyzing customers or outcomes blinded?
Actually, I can't tell because the research paper doesn't give a detail whether actually people who analyzed the study were blind or not, because that was possible. And so, but I can't tell. Paper doesn't. I couldn't find in the paper. Maybe somewhere I just tried to find, but I couldn't find.
All right, thank you, Doc. Now, here we go with the next one, which is, were the study groups similar at the start of the randomized controlled trial?
Yes, study groups was similar at the baseline. So this chart actually gives distribution of the patients in both arms. We can see the age, comparison, BMI, in terms of causes of infertility, duration of infertility, dose of stimulation. So and they compared these two groups, and they were very similar at the baseline.
Thank you, Doc. Next one for methods, apart from the experimental intervention, did each of the study group receive the same level of care?
I think overall, yes, because if we just go by this intervention map, we can see that here they were randomized, and on day 3, then they moved to fresh or frozen cycle, and I can't see any additional interventions, and they seem to just had a fresh transfer or frozen. These actually interventions, but because 18 centers participated in clinical trial and they had their routine clinical practice, unless they treated frozen cycle differently to fresh in addition to the actual intervention. It's really hard to tell, but the study researchers stratified the randomization, which means stratification means you don't get disproportionately more patients in one arm from one single center. So which means that each center, 18 centers, had a similar number of fresh and frozen cycles, and hence, because of stratification, you can overcome this kind of some methodological issues. So I believe that the participants were treated equally, except the intervention or frozen transfer.
All right, thank you, Doc. Moving on to the results question. Were the effects of intervention reported comprehensively?
Yes, the article reported the results comprehensively, and so there's a very detailed explanation on power calculation, dealing with incomplete data, people who actually excluded themselves from the study after randomization. So we have full information on that on the paper. But again, I have a comment on the power of the study. Like in previous RCTs we reviewed, the biggest problem we have in RCT general, especially in IVF, we are seeing a lot of underpowered studies. So if I let us examine that this part of the study, because actually this helps us to define whether how much of this evidence we can use in clinical practice. So the study was powered for the outcome of healthy baby, which is really a stringent outcome. Because it is less frequent than the rate of healthy baby is much less even than live birth rate, and the effect size was powered for effects. So effect size was planned for 8% increase. Let's say if baseline rate of healthy baby after IVF cycle, if it was 17%, a study group assumed that intervention, which is freezing of all embryos, will increase live birth rate, no, healthy baby rate by 8%. This is a massive jump. We discussed in detail yesterday when we discussed RCT power calculation. In IVF, typically you don't see any intervention which can increase live birth rate this much, especially healthy baby rate. It's even difficult. So this was a very, in terms of assumption, 8% increase was it's very high aspiration. So yeah, so even on that basis, they plan to recruit 1,086 patients, but they managed to recruit 619 patients before the study was terminated. So it's a very, very, very underpowered study. So according to the Manchester Group's recommendation, so it is recommended we should aim to get 5%, at most maybe 5% increase in terms of effect size in live birth rate in IVF. Because as we said, IVF is multifactorial intervention, and usually we don't see big jump in effects in terms of effectiveness of any treatment intervention. If we go by the advice of the epidemiologists and statistics group in Manchester, we should have set this number to 5. Then which means then you would plan to increase plan this sample size calculation on increase in effect size from 17% to 22%, which is 5% increase. That would bring up the sample size to 2,634. From the outset, this power calculation was done, I think, for much lower number of patients. So actually, we are not even talking healthy baby, because this recommendation from Manchester is 5% for live birth rate. A healthy baby rate, you would expect even lower increase, probably 1% or 2% with any intervention, maybe at most 3%. Let us be generous and say we want to have a 3% increase from 17 to 20. Then you would need 7,000 patients in total. Again, this is a chart from HFA, which is showing that during 28-year period of time, we are managing to increase live births by 0.6%. I'm sure that healthy baby rate annually in UK increases even less than 0.6%. So that's why with any intervention IVF, you won't expect that any intervention can increase healthy baby rate by 3%. That's why if in order to get a realistic, real life power for the study, even if you're generous, you should have given 3% increase from 17 to 20. Then you would need 7,000 patients. So probably recruiting 7,000 patients probably would give sufficient power to answer this research question. So if you look here, sufficient power for this kind of RCT, this RCT probably would be to collect 7,000 patients in total, which means 3,500 patients in one arm, 3,500 patients in the other arm. But the research group planned to collect 1,086 patients, and they managed to collect 691 patients. On the basis of this, we can tell this study was severely underpowered. And actually, the research group recognizes it. And in conclusion, they said, yes, we can see some trends here, but we cannot be sure because the study is so underpowered. So yeah, so overall, the validity in terms of methodology of the study is there's no question this is really of high validity and methodological achievement. But in terms of power, this is really, really underpowered study.
All right, thank you so much, Doc, for further explanation of that point. Now, next question here on the results, of course, is was the precision of the estimate of the intervention or treatment effect reported?
Yes, group reported confidence intervals very detailed, and there's a very thorough, detailed statistical report in the methodology, in also results and discussion. Yes.
Thank you, Doc. Now, finally, on the results, we have here the last question. Do the benefits of the experimental intervention outweigh the harms and, the harms and the cost?
No, actually, it's opposite. They found that control, bearing in mind this very, very underpowered study, we cannot come to this conclusion, but given the data they have, and they said that actually control group had a better clinical outcome, which means higher rate of healthy baby rate, and also cheaper in terms of cost effectiveness. Unlike previous RCTs we reviewed last week, this RCT actually did cost analysis between fresh and frozen, and they found fresh transfer is cheaper in terms of cost compared to frozen transfer. So the benefits of treatment intervention, which is freezing and transferring in frozen embryo, does not outweigh the benefits of fresh transfer. Yes, so this is a summary table of our CASP review. So overall, here we can say that study was validity of study 100% was valid study. Methodology was very good. In terms of results, really study was so underpowered, and it's difficult to use this study evidence alone as evidence based, but we can use is other randomized controlled trials and observational studies in terms of understanding whether fresh is better than frozen embryo transfer. So now if we decide whether we should keep this study in our library and use our research practice, whether we should actually not use this research paper for our research and clinical practice, overall, because it was valid study and it added some information to our knowledge, and more importantly, it added more data for future meta-analysis, systematic reviews, and this is why we need to keep this study for use in clinical practice. But we should bear in mind that the powers of this study is very, very weak, similar to previous RCTs in this research question. Thank you. Okay, so yeah, thanks, Jesse. Yeah, so we will have maybe a couple of RCTs left to answer this research question, like we discussed.
Yes, Doc. And of course, definitely, again, to everyone who's watching right now, that was, of course, the IVF Journal Club live stream for you, and that's elective freezing of embryos versus fresh embryo transfer in IVF, a multi-center randomized controlled trial in the UK with Dr. Oybek Rastomov. Again, to everybody, please go ahead and check out all our social media pages, our website as well, rastomov.com.au and adorafertility.com.au for more information. Again, join us again for another exciting episode of IVF Journal Club with Dr. Oybek Rastomov. Doc, thank you so much.
Thank you. Thanks everyone for watching the live stream. We'll catch you next time. Thank you.